Hello, my name is Dr. Hisham, and today's topic is pericardial effusion. Pericardial effusion is accumulation of the fluid in the pericardial space. You know that the heart it is surrounded with the pericardium. It has two layers, the serous layer and the fibrinous layer. A normal fluid in a pericardium, it could be up to 50 ml. So up to 50 ml, it is normal. Doesn't necessarily means that in every person it is up to 50 ml, but up to 50 ml that could be normal. And strangely, this pericardial space that can accommodate up to 2 liters, conditioned that it builds slowly. So it can go up to 2 liters. Definitely that's abnormal. That's not a normal thing. But if that develops slowly, it can accommodate up to 2 liters. That's quite a huge volume. Um, but here, important is that if I said that if it builds gradually, but if it develops rapidly, even a 200 ml can produce symptoms. So as I said that normally it's 50 ml, it could be up to 50 ml. It can accommodate slowly up to 2 liter. Isn't that strange? But a rapid accumulation of even a 200 ml that can produce the symptoms. So what's the etiology importantly? What are the causes of pericardial effusion? There are a number of causes like infections, most importantly TB. Then the second thing is malignancies, mediastinal radiopathy, then uremia, if someone has got CKD, so uremia, then connective tissue diseases like rheumatoid arthritis, then post-cardiac surgery are some more serious things like ventricular rupture or aortic dissection. Then hypothyroidism can also cause, and the pericarditis itself can lead sometimes to pericardial effusion. So what you're going to find on the examination and the investigations, what you find over there. So let's start from something serious, that backstriate, okay, when it rapidly, the cardiac tamponade, when the effusion is so large, it develops rapidly, it can lead to we say is a backstriate. So what's a triad is that in the backstriate, it is you have muffled heart sounds. So muffled heart sound, if I write it like this, then you have low BP and you have raised JVP. So this is something that is that's an emergency. So backstriate. So muffled heart sounds, low BP, raised JVP. Okay, so that's a backstriate. That could be if it accumulates too rapidly or if a large volume of pericardial effusion is there. Then what you can see on in ECG. On ECG, you can see what we call electrical alternance. Let me show an ECG. So you can see there here it's a normal complex, okay. This one is a small one, QRS. This is again a normal one, small normal. It is actually caused by swinging motion of the heart in this pericardial effusion. So the heart is actually has a wobbly motion. It's wobbling, it's swinging in that fluid. So this gives a characteristic pattern on the ECG that is called electrical alternance. So one normal, one small, one normal, one small. You can appreciate it over here. Then on the X-ray, if we talk about the X-ray, you know that on the X-ray you can find a globular heart. That's it has a globular appearance because of this pericardial effusion. On ECG, if it's large enough, sometimes it's not the electrical alternance, but a low volume, low voltage complexes on the ECG. So it's a low voltage ECG sometimes. Then you find a pulsus paradoxus. What is the pulsus paradoxus? This is a sign you find in pericardial effusion. So in the pulsus paradoxus, there's a fall in the systolic BP. greater than 10 mmg on inspiration. Just remember that on inspiration there is a fall in the BP, and how much is that? Greater than 10 mmHg. This is called pulsus paradoxus. So I'm gonna just summarize these things, these signs on examination on the ECG. So what's going to be the pulsus paradoxus? That's a fall in the BP, systolic BP greater than 10 mmHg. Then you can find a back triad that's you have low BP, you have raised JVP, and you have muffled heart sounds. On the ECG, you can find electrical alternance, or you can find a low voltage ECG. Okay. Then on the X-ray, you can find a globular heart. Uh, okay. What is definitive thing you're gonna do? That is an echocardiography. So in echocardiography, you can find that this is hard, fourth chamber. You can see and hear a large, very large pericardial effusion. Then here you can see a four chamber view as well. You have right ventricle, atrium. So on the echo, you know that you see upside down. The left is right, right is left, and it's upside down like the chambers which are down actually normally when you see a patient. So they appear up. So ventricles will be up, and the atriums will be down. Here you can see pericardial effusion here. So the definitive is echo. You're going to find out the volume as well as you can see an evidence over there. That's a visual evidence that it's a pericardial effusion. Then what is the treatment at the end? So treatment is pericardiocentesis. Okay, you put a syringe, okay, as it's shown over here, under the radiological, like you do an echo. The best thing is that electrodes are attached to the cardiac, and you put an echo probe, and then you pass a syringe from the Z5 process. Okay, and then from the left side. Can't tell you exactly the technique over here, how it's done, but under this echo of yours, okay, you can put a syringe and you can draw the fluid. Then the other thing is that if it's a recurrent or it's chronic or it's malignant effusion, then there is a technique that is called percutaneous. I'm going to write it PCT, pericardiotomy. Okay, PCT, percutaneous pericardiotomy, that you do for chronic or malignant pleural effusion. So that you can leave this catheter over here and draw the fluid, and you can keep it for some days as well.